Thank you for the wonderful introduction, Mary. Delighted to be here talking to you about the COVPall study with my colleague Rashmi. So COVPall, the aim of COVPall study was to rapidly evaluate the COVID-19 pandemic response in palliative and end-of-life care. It is set up as a multinational study looking at workforce changes, innovations, and symptom management. So quite a number of people besides me and Rashmi have contributed to the project. We have a huge team of excellent researchers and also study partners and study funders, and quite a number of unnamed people, researchers have also contributed to the study. So what I will be talking to you about is the context in which this study took place and how the study worked with evidence and PPI consultations and to set up the setting of the study. Then I will be talking to you about the what happened actually on the ground, and then briefly touching upon the findings and main outputs from the project, including and how they were disseminated. And finally, taking some time to discuss with you, with Rashmi joining me in, about how we have ensured maximizing impact and how we have explored different pathways to impact, such as through clinical networks, researcher networks with policymakers, as well as involving patient and public in this process. So it was very important to, first of all, understand and accept the wider context in which the COVPall study was conceptualized. So palliative care, being a holistic care with the aim of relief of suffering, is very much used to dealing with life-limiting and often severe illnesses. And COVID-19 being one, we saw it as very relevant to the pandemic response. However, not the same was, this view was not shared widely at international or national level. A lot of international and national guidances missed and did not recognize the importance of palliative care in this pandemic response. Hospitals were built, many reports were produced, often not talking about palliative care. So this has motivated us to find other ways of capturing the importance of palliative care and its potential role in pandemics. So we, at the very beginning, before the study, aimed to capture public and patient views and worries and priorities for the COVID-19 pandemic. So we basically mobilized our Sisley Saunders Institute PPI online form, and the link to it is provided at the end of the slide. And I would really recommend highly for you to sign up and link with public and members of public and patients through the form. So mobilizing this form, we immediately carried out a very quick survey and received quite a number of responses. And in this way, we've produced a consultation document which reported the experiences, concerns, and priorities of palliative care research during the COVID-19 pandemic. And we have used this consultation to motivate the COVPall study. So here is the link to the report. You can read it in full. But basically, what we called the missing voices of patient and public, they expressed quite a lot of anxieties around expected reduced professional support. They had voiced quite a lot of concerns and fears over reduced quality of care. And they also expressed quite a lot of concern with regards to strains on informal care networks and being overburdened by increased responsibilities they as informal carers had to take on. And of course, they have expressed quite a lot of concerns about the increased losses, grief, and bereavement throughout this process. So we basically have looked at literature very quickly of what was being published on palliative care and its relation to in pandemics. So quite very limited literature existed. One looking at the role and response of palliative care in previous pandemics. So quite a lot of lessons learned of how palliative care is relevant to pandemics in general. We also looked at some studies, international studies from Italy, and a study from London, King's College Hospital, looking at symptoms and their management. And we decided that quite urgently COVPall study was needed. So in setting up this study, we wanted to ensure that we included all the regions, that we attracted partners from all across the UK. So we didn't want this study to be a London-based study. And we therefore used our networks and the National Applied Research Collaboration national leadership in order to identify potential partners for this program of research. So national ARC leadership at the very beginning of the pandemic produced this live document. It's a live register with all the COVID-19 related research that is undertaken by palliative and end-of-life care researchers, clinicians. So we automatically registered our interest here. We looked for potential other partners, and we have identified and approached them. So we then set up, we started looking for potential funding streams, and we identified a rapid call. So we generated, working with our partners, we have identified that there was an urgent need. Evidence was needed to understand where the highest need was and what treatments were being used and how effective they were. We also wanted to make sure that we capture the palliative and end-of-life care response, because we thought there's probably quite a lot that could be learned from the experiences of palliative care teams in palliative care, and also lessons to be learned that were relevant to other professions and specialisms beyond palliative care. We also wanted to make sure that we document that palliative care did contribute to the COVID-19 response, and we wanted to capture the innovations that they have produced, the challenges such as shortages of equipment and other issues, staff shortages that they have experienced in palliative care in responding to the pandemic. So the aim of the study was to evaluate the palliative care response rapidly and understand symptom management as well. So the study was composed of two parts. The first part, called the Work Package 1, was an online survey of palliative care services, aiming to capture palliative care response to the pandemic. Work Package 2, which was designed as a cohort study, aimed to collect patient-level data to understand better the practices along symptom management of COVID-19 patients seen by palliative care services. So getting ethic approval was quite challenging for both work packages. For Work Package 1, which was service level data collection, it was a little bit easier. We had convinced the ethics committees that we would not be recruiting from NHS grounds, and we're not recruiting patients for that reason. And our recruitment was through professional organizations such as Association of Palliative Medicine, etc., or Hospice UK, and many other such professional organizations that only a university ethics was found to be sufficient. So that was very quick. We targeted voluntary hospices, hospital-based palliative care teams, home care community teams, adult and both children's services. We also recruited quite a lot of services through our partner organizations, such as the European Association of Palliative Care and some other national partners that we have, such as Sue Ryder and many other partners that we had. Patient level data collection and work package 2 was a little bit more challenging because it involved patient level data. We had to go through HRA approval. We unfortunately, being working in palliative care, we were not prioritized for fast track evaluation. Most of the COVID-19 related studies were, so we were very disappointed in that process. However, we did not, we persevered. We had to make some changes to the way we collected data, but we could only get approval for England and Wales. Still quite a big contribution, quite a big accomplishment, but we did want to make this a national study. So we basically used RedCap, which is an online data capture database, which really quickened the process of data collection. We generated random IDs where patient level data could be entered. So as we were not getting information directly from the patients, consent was not required. So that made everything a little bit easier to run on the ground. So the project duration was very short. It was only a 12-month project, and the project actually closed on April the 19th. But we had to be very flexible because there were some things that we didn't guess from the very beginning. So we had to adapt and adjust the project stages very quickly. So we were in the beginning hoping to carry out 2 rounds of survey runs, both patient and service level data collection, but we ended up just carrying out 1 longer run of patient and service level data collection. But the funders were very responsive and understanding and accepting of these changes. So regarding findings, outputs, and their dissemination, there are some, I would like to now share with you some of the main findings, but most importantly, I want to share with you some strategies that we have used to make sure that the findings were very quickly published and shared, not only for researchers or academics, but also with policymakers and with public as well. So we had at the very beginning set up a dedicated project website, and there is the link. And we made sure that we produced newsletters almost monthly. And we found that producing of the newsletters and however preliminary, sharing our findings and experiences with the participating sites or audiences was really helpful in motivating them to contribute more and more to the study. We took every opportunity to present, no matter how uncomfortable sometimes we felt, in numerous meetings, including ECHO calls, the AIIHPC, National End of Life Care Steering Group meetings. So we did end up joining quite a lot of closed meetings to make sure that what the services were telling us and what we were finding out about the patients were very quickly shared. We also utilized blogs. So we had quite a number of blogs that we published. And the moment we submitted our official findings, we also made sure that they were published in preprint, because as you know, it takes a while from submission for papers for findings to go through review, peer review, etc. So we basically made the findings and the papers available in preprint format as soon as we submitted them. We also underwent as a team, again under the leadership of national applied research collaboration trainings. We attended how to prepare policy briefs, and we automatically used this information and made sure that we were producing policy briefs, so 2-page policy briefs. So these are the policy briefs that we have produced, and the links to them if you like to see them. And basically, we produced recommendations, action plans, if a second pandemic was to occur, based on the COVPall study findings. We talked about we produced a policy brief on service innovation and practice change. And we produced a policy brief on advanced care planning, which were the main 3 outputs from the study. So I will briefly touch upon the findings of the study now. So we produced an overall paper survey, which reported the results from 458 services all across the Europe, across the UK and rest of Europe and the rest of the world. So quite an international and national data sets. We had responses both from charitable as well as private settings. What our findings showed us is that 81%, so quite a lot of services had cared, palliative care services had cared and seen patients with confirmed or suspected COVID. So here, the main message is that yes, palliative care services did take part, were active in caring for patients with COVID. And very interestingly, more than 70% of the staff working in the palliative care services had COVID-19 themselves. So we have also found out that most of the services, palliative care services, were seeing patients who had multiple long-term conditions, who were not known to palliative care. So about 70% of services saw new patients that have these multiple long-term conditions. About half of the services saw patients that were known to palliative care. So they were palliative care patients returning or developing COVID-19. And about 40%, so 37% of the services were seeing patients who were previously healthy, who were severely affected and dying with COVID-19. So very interesting mix of patients that the services were seeing. Some new and known patients, but most of the services were seeing new patients who were dying with COVID-19. So other highlights from the main paper was that PPE shortages were most of the services, so about 70% of the services that were charitably funded experienced PPE shortages compared to the 29% of public services. So basically here we can see that there is a disparity between charitably funded and publicly funded services. And also staff shortages were quite high. So 46% of the services in the UK compared to the rest of the Europe and the rest of the world experienced staff shortages. So these are main highlights of the COVPall study. So we've seen reduced inpatient palliative care unit activity, definitely increased activity for home care and hospital teams. Support from volunteers were considerably reduced, affecting specifically community services, and shortages were common, especially shortages of staff and PPE. So another main finding was that in terms of advanced care planning, that looking at advanced care planning, there were quite a number of challenges at different levels using this ecological model. I'm not going to go into it too deeply, but the main I just want to give you the main highlights, and the link to the paper is at the top of the slide. You can read it at your own time, but the main finding, one of the highlights, was that services, palliative care services, adapted to local processes. So they were prioritizing specific components, they were integrating into everyday practice, advanced care planning into everyday practice. And one of the main highlights was that the starting point to any discussion should always be the patient's values and priorities. So another main findings was about the innovations that was produced, and the innovations were frugal. And again, the full paper link is there at the top. So basically, palliative care services were very innovative, and they were very innovative very quickly. They combined teams, changed staff working to provide a 7-day service 24/7, being on call 24/7. They opened, even if they didn't have before, bereavement support to all families in the area, not only to their own clients. So those are some of the very interesting innovations that services have produced. An output looking at the volunteers, and this is from a preprint, a paper that we have very recently submitted looking at the volunteers, found that quite a lot of services experienced change in volunteers, so reduce volunteers. And of course, this has implications for some of the services that hugely rely on volunteers. So one of the main highlights of the paper looking at volunteers, or our findings on the volunteers, is that consideration needs to be given to widening the volunteer base away from older people who may be more likely to be affected by COVID-19. So the implications could be because the importance of volunteers for palliative care. And this paper has outlined the importance of volunteers and their absence during the COVID-19 pandemic. We had also produced an output looking at the inequalities. Of course, inequalities have been very much uncovered during, and have been one of the main topics throughout the pandemic. A paper led by one of our colleagues looks at the inequalities, and it looks, this paper is currently under review. It looks at that there's definitely a disproportionate adverse impact caused by the restricted visiting. Of course, this impact is even further compounded by communication challenges of persons from different cultural backgrounds. Quite a lot of discussions pointing to the unmet religious and faith needs of diverse, of persons from diverse cultural and religious backgrounds, and the importance of equitable services. So equality, but maybe more importance towards equitable services. We also have looked at the role of palliative care services in educating others. And again, just a highlight from this output, which is unpublished still, we're still looking at this data, is that palliative care teams did do a lot in terms of educating other teams with IPU skills, educating them, training them on how to administer, how to carry out clinical frailty assessment, and many other, in many other skills. A team of us is looking at the changes in the business levels, how busy the services or less busy they have got. And it is very interesting. So for example, you can see in Northern Ireland that 50% of the services reported to being more busy than previously before the pandemic. And this paper and this output captures that overall in all the UK regions, that services were definitely, palliative care services were more busy. And this could be explained by the observation that the palliative care services were already dealing with their own patients as well as seeing new patients with COVID-19. And a modeling for this output also showed that community services and those that were publicly funded were much busier than others. So now talking to you, I want to take a few minutes to talk to you and share with you some of the preliminary findings of, that emerged from the patient level data. We are currently looking at this data with Professor Higginson. So we have captured data from 573 consecutive patients. We have asked the services to select a period and report on consecutive number of patients to avoid selection bias. We have included patients that were clinically diagnosed or test confirmed with COVID-19, and they could have pre-existing progressive conditions as long as they were adults. So we tried to collect data at 4 time points. Of course, each patient at least had baseline data and final assessment data if they might have died before the 4 data points could be collected. And we captured symptom severity or effect of the symptoms by using integrated palliative care outcome scale that we have specially developed for COVID-19 patients. And if you're interested in patient-reported outcome measures, I've just put in the link to where all our measures, all our patient-reported outcome measures, including the one that we have developed for COVID-19, could be accessed freely and freely used. So here we see that most of the table shows that most of the patients that were recruited to the study were new patients. So they were previously not known to palliative care services. So about 425 people out of 573 were new patients. Very few were known to palliative care services beforehand. There's a good representation, mostly being white, and good representation across different socioeconomic status or deprivation levels. So quite a rich data set. So on the left is just a graph showing you the dates of admission. So we have basically admitted patients beginning from 18th of February 20 to February 21. And it shows the counts of people who were recruited to this study. And here you can see that about 60% of the recruitment or patients recruited were from wave 1 of COVID-19, and for about 40% came in or were admitted during wave 2. So again, a good representation. Quite a lot of persons admitted had comorbidities, about 30 or a third of them having 2 or more in addition to COVID-19. And the outcome for most of the patients, so about 73% of the patients that were recruited to the study ended up dying during or slightly after the observation period. with only 26 or around 26% being discharged or still being in the care. But it's of course in the study observation period, which is, if you add up, it roughly comes to 4 days of observation. So people have more people may have died beyond this point. But you see that out of the new patients, about 20%, 21.4% to be more exact, were discharged or still in care, compared to 48.6% of the patients known to palliative care services. So it looks like patients who were known to palliative care services did have a better survival. So here is a survival curve looking at the level of breathlessness or breathlessness baseline score. And here you can see it and it shows the survival trajectory. So it basically shows you that patients who had overwhelming breathlessness, shown by the red line, the first one at the bottom, who experienced overwhelming breathlessness, actually died quicker. They have a more steep downwards trajectory compared to persons who were admitted with slight or did not experience breathlessness at all. So this shows us that breathlessness and its measure of it is quite a good indicator of a predictor maybe of survival, or how this survival curve would look like. And here's more presentations from the data. Basically the ones at the top, the spider graph on the top, shows that if the patients were referred less than 2 days before their death, palliative care services still, or palliative care teams still were able to manage their breathlessness. So the green line is where the breathlessness, for example, or symptoms they experienced when they, percentage of symptoms they experienced when they, percentage of people who experienced symptoms when they were admitted, and the black line when they died. So second assessment. So it looks like breathlessness was quite well managed. Anxiety was quite well managed. Agitation and pain, most of the confusion were quite well managed by the palliative care teams, even though there was not that much time for them to intervene. The bottom two radar graphs show you that the outcomes for the patients who were seen by palliative care services 2 to 4 days before their death. So again, you can see that palliative care services managed breathlessness, managed agitation, anxiety, and few other cough, pain quite well. And those patients who were referred to palliative care 4 days or more before their death, they experienced improvement of their symptoms as well. So here, the overall message is that palliative care teams and their interventions are quite effective, or are good at managing symptoms that are quite distressing for persons. So I'll just take a few more minutes before I hand over to my colleague Rashmi to talk a little bit more. But the impact, and thinking about impact from the very beginning, even before conceptualizing this study, was very critical. And it was really, we tried all the known ways and explored new pathways to impact. So the COVPall main study gave rise to few other studies that got successful funding: COVPall Care Homes, COVPall Connect, HGR UK, NIHR funded studies. And the secret for this was that we did encourage other teams, and we didn't have to be involved, to come up with and use our templates and to apply for funding, to apply lessons learned or our surveys in settings that we were not able to reach. So, for example, the COVPall Connect study, we are now in the process, which is HGR UK funded. We are in the process of looking at ways in linking routinely collected national data with service level data to understand the data better. And there's a link to it if you're interested. We have made our parts of our data sets, or sometimes whole data set, available for other researchers and organizations. For example, part of the COVPall findings and data, and we had to carry out new analysis, became part of the Better End of Life report of Marie Curie in 2021. So we basically advertise that we do have this data. We encourage teams to make use of this data. So data sharing was very critical. We tried also to put our findings in new formats for here. For example, we developed an action plan. So we have tried to share our findings at national platforms as much as we could in order to invite researchers, let them know of these data sets that we have, such as we've joined UK echo calls, we have used National ARC leadership to carry out specific and present specific findings from the project. And Rashmi, I think it would be wonderful if you can talk us through some ways in which PPI could be a milestone on a pathway to impact. Thank you.
Thank you, Mev. Some of the outcomes and findings from this study has been how to engage and how to get PPI involved even more, particularly during this difficult and challenging period. And some of the things that came out from that is the need for compassion towards those who contribute into the research projects, got to understand the difficulties and challenges of the PPI by the very nature of what a lot of these PPIs have got other responsibilities, other duties, and stress, emotional stress, physical stress. So it's important to be compassionate towards those who contribute into the research projects. Timings of the meetings, got to understand that we can't just be restrictive to 9 to 5 working. Got to be flexible. Timings, allowing enough notice for the members of the public, patients to be aware of the meetings, for them to coordinate their other activities, and that came out loud and clear. The use of communication, not to just rely on digital communication or non-digital communication, paper communication, but looking at all type of communication, Twitter, online forums, and other types of communication, including their own social networks. Improving the lives of the persons living with multiple long-term conditions. Patients are usually not suffering from one condition, they will have multiple conditions, and to be aware about, by the very nature on some of the studies, it may be focused on a specific review or specific analysis and understanding, but patients have multiple conditions. To be aware about those conditions, to be engaging with those patients and PPIs, to be aware about the delivering competent and culturally sensitive services to meet the needs of the residents from diverse communities, diverse ethnicities, diverse physical and mental health conditions. The key lesson that came out from that is also the need to have a dedicated person who is a multidisciplinary specialist that both the PPIs can interface with to effectively act as a conduit to interface with the researchers and also to provide the support. And research is not just about cancer. We got to be mindful that there are a lot of palliative care needs, such as trauma, stress, motor neuron disease, cardiovascular diseases. To be aware that palliative care goes beyond the cancer. Traditionally, a lot of the members of the public may have thought palliative care, and researchers too may have thought it's all about cancer, but it's beyond the cancer. And it's important to recognize that. We recently had a workshop where we brought researchers and the members of the public, PPIs, together. And the key findings that came out from that workshop was just engage with people, ask people what they would like research to be done, not to presume that the research needs to, that patients need a certain type of research. Ask them, engage with them, use various types of communication, such as art, visual arts, physical arts, and that can therefore communicate the message better from both patients' perspective as well as from the researcher's perspective. And also allow, a lot of the PPI is perhaps not actively used, and some people do not get involved with PPI because they may have had bad experience of health or social care services. Allow time to discuss about the bad experiences so that we can learn, we can collectively learn on how to improve those services, and not to just give up and disregard them. Trying to look and understand the diverse experience of exclusions, because there are many reasons for exclusions. It's not just about digital and non-digital. There are numerous challenges, time, notifications, support services. All that needs to be considered. But crucial to that is researchers needs to be compassionate and flexible to have the maximum and effective PPI involvement in, and that can work both. It can be effective and productive for both, and create opportunities for, because the other thing is it's important to recognize that if we motivate PPI, then PPI can actually positively contribute into the future research. So allow and create opportunities for them to socialize and build communities, because they can actually work to disseminate the information out there into the public so that the research, when it's produced, it doesn't stay. They can actually help with lobbying the policymakers to deliver some of the outcomes of the research. And I think that's the key message that came out from this study. Thank you, ma'am.
Thank you, Rashmi. That's a great. Thank you so much for listening. And I think we are ready to hear your comments or answer your questions.